Bismillahirrahmanirrahim. Today we will have case quiz number 36. Case data: 58 years old female with history of 1 month history of jaundice, pruritus, pale stool, and dark urine. By investigations, she had total bilirubin within very high 4.6 and diet bilirubin 3.3 mg per deciliter. ALT shooting 300 and over. Alkaline phosphatase also raised. Gamma glutamyl transpeptidase also raised, very raised, 1000 and over. Carbohydrate antigen also raised. Contrast enhanced CT with biliary reconstruction showed wall thickening of the entire bile duct and segmental stenosis between the dilatational part confirmed by MRI cholangiopancreatography. Initial treatment for this case: based on symptoms and lab data, she was then diagnosed with cholangiocarcinoma. Laboratory confirmed a coarse texture of the common hepatic duct and 6 cm long wall thickening of the proximal bile duct, originating from the start of the common hepatic duct to the intrapancreatic bile duct. The affected bile duct was excised, followed by the choledicoplasty and raw NY anastomosis. The outcome: she recovered well after the surgery with ameliorated jaundice and normalized liver enzyme levels. However, the pathological examination revealed no malignant cells, so this is not the case of cholangiocarcinoma. Instead, plasma cells, lymphocytes, infiltrate, and hyperplasia of fibrous tissue were observed in the specimen. Immunohistochemical staining was positive for CD138 and IgG. So, what is the diagnosis? The answer is yes, think. The answer is not malignant, is not cholangiocarcinoma. The answer is IgG4 related disease. This subtype of IgG4 related disease is called IgG4 related sclerosing cholangitis, IgG4-SC. IgG4 related disease: the differential diagnosis between cholangiocarcinoma and IgG4 sclerosing cholangitis is challenging due to the significant overlap of clinical manifestations, lab tests, and imaging characteristics. Lacking definitive diagnostic criteria for IgG4-SC, histopathological findings are critical for the diagnostic establishment, so this case is only diagnosed with histopathology. The histopathology include dense infiltrate of IgG4 plus plasma cells and the severe interstitial fibrosis. Furthermore, the presence of increased serum IgG4 concentrations and involvement of extrabiliary organs also strongly suggest IgG4 sclerosing cholangitis. Due to the clinical rarity and the poor recognition of this entity, it is not surprising that the progressive measurement of serum IgG4 could be missed, especially in those without explicit clinical manifestations in extrabiliary organs. Without therapeutic guidelines, glucocorticoids remain the first-line agents for symptom improvement and organ function restoration. Alternatively, surgical resection was indicated in patients with suspected malignancy proved to be effective for symptom relief. Notably, relapse occur in over 50% of patients after steroid withdrawal and 44% after surgical intervention, because this case is an autoimmune disorder and need lifelong or at least very long time therapy. Given the age, gender, clinical and imaging characteristic of this patient, hilar cholangiocarcinoma was the primary suspect. This is the logic diagnosis. But endoscopic retrograde cholangiopancreatography might fail to examine the whole bile duct due to the full-length stenosis, so diagnostic laparotomy could help. However, as an afterthought, typical cholangiocarcinoma rarely present full-length wall thickening and stenosis of bile duct. Thus, it is advised to preoperatively assess the IgG4 level for patients presented with long bile duct involvement, and IgG4 sclerosing cholangitis should be considered if elevated IgG4 exists. And finally, thank you very much for your attendance and see you tomorrow with case quiz number 37. Wassalamu alaikum wa rahmatullahi wa barakatuh.